Thank you for the nice introduction. I will talk about maybe 3 types of populations that I work with. The first one will be as a maternal fetal medicine subspecialist. And in Los Angeles, where I practice, we get patients referred to us. And some of our patients, from a perspective, they have various complications of pregnancy. And usually, I would say about half of our patients are probably obese that come to us. But when they're referred, the obesity is not really mentioned. So that's one population. Then I'll talk about another population where actually sometimes act as the supervisor of the residents in a routine obstetrical practice in which there are midwives there. We work with midwives in that center. And again, those patients are usually a high risk. Many of them are migrant population, low economic population as well, in which in that population probably the obesity range may be up to about 60%. And then I'll talk about the global health community that I work with. I once a month do an international global conference in which you have institutions from Uganda, from Rwanda, in fact somebody from Switzerland just joined us, as well as from Ghana. And from those institutions, someone presents one of their maternal cases about some morbidity or near miss, and then we help them go through what various processes that you can do in your community to try to improve care. So that the various communities that are working. And then in addition, I do teach residents and medical students as well as fellows. And one of the issues, again, with that population is how do you make them aware even before they become faculty, all right, in being able to be more cognizant about nutrition during pregnancy.
Wonderful, thank you. Josephine?
Okay, the clients that we serve in public health are through our health departments as well as through the private sector, because we have a close connection with those receiving care within the private sector, particularly funded by our state's Medicaid program. The women we serve are most frequently lower income. They are addressing many of life's stresses. They often work in low-wage jobs. They have families. They are attempting to get their kids to childcare, work, get their kids to school, and give their families all the same things that we're trying to give our families. I would say that in terms of the work we do, we try to give them quality care, and we're interested in making sure that no matter where they're served, that they do receive quality care and their needs are addressed. Their needs are great and go well beyond the needs of their weight gain. It's doing that in the context of all the other stresses that they have, juggling food insecurity, where their rent's going to come from, and how they're going to have their kids, often they already have children, be a part of activities that the other kids in school settings and childcare are going to do. So they're balancing many, many things without certainly without the financial resources, and often with the next day worrying about how they're going to feed their families and get to their next appointment. So I would say that they're women who are have a lot of life stressors on them during their pregnancy and between and after their pregnancies. And so we work to provide them the kinds of support or programs that will help them mediate those issues as best as we can with the resources we have in our state.
Hi, thank you for inviting us here today. This is a wonderful opportunity to talk about such an important issue. In terms of ACNM, midwives, as she mentioned, do about 12% of the vaginal births in the United States, and that's across populations in all settings. 95% of the births that midwives perform in the U.S. are in hospitals. And so in terms of my representation of those midwives, I can say that there is a lot of diversity there, but traditionally we have served a large percentage of vulnerable populations. In my personal practice, I still practice clinically in inner city Baltimore with a 98% Medicaid client base. I've also practiced in a birth center settings with Orthodox Jewish populations. In our community, also in Baltimore, we have a lot of Hispanic women. And so there are just a variety of cultural issues that come to the table when you're talking about what you're going to do to really motivate people to change behavior. And as Josephine so eloquently stated, women have so many other issues going on that really are so important to their lives. How do you get to an appointment, with 3 little kids and a bus system and that's not working right? How do you feed people a healthy diet when you don't have access to to good food in your community? No fresh foods are available in a lot of communities. And so how do you work beyond some of the cultural norms in terms of what the Hispanic populations want to eat that may or may not really be conducive to losing weight, for example? So there are a multitude of issues. I think that what it comes down to for midwives is really establishing the interpersonal relationships with women during the prenatal course of care that will enable them to then get to the heart of what's really going on, doing some of the motivational interviewing techniques where you can really find out why someone is not able to change their behavior, or what are the key elements that need to be put into place so that behavior change can occur. It's hard to tell patients to exercise when their neighborhood isn't safe. There's no mall nearby. They can't get their kids to the park very easily. And so just trying to find solutions that work really takes that one-on-one, time-intensive sort of therapy, if you will, that I think that is lacking in the current structure of our prenatal healthcare system. And I really applaud the efforts to try to expand the postpartum coverage. I think I am totally in agreement that we need additional visits beyond just the one visit, in which most providers are really focusing on a woman's healing, and the woman is focusing on just being overwhelmed with this new pregnancy and the physical changes and emotional changes that have taken place. It's a really difficult time to address your weight gain or your weight loss that needs to happen. And so we need to build additional frameworks within the system so that we can really get at this big public health issue that needs a lot of prevention on the front end.
Thank you. Okay, so now I'm going to just challenge the panel a little bit, just to kind of take us to your organization, take us to a typical day, like really take us on the front lines, and talk a little bit more specifically about what you have in place or what you're currently doing already to try to meet some of the needs of your clients, kind of lessons learned, if there's new programs that are being implemented or programs that did or did not work in the past, but kind of give us a sense of what it's like when the woman's sitting there in front of you and what you do to help her, support her in behavior change.
I would maybe start, first of all, from the national level, what we've done. I think for you to be able to first be able to counsel people on diet, nutrition, and exercise, you have to have some knowledge about it yourself, and you probably have to practice some of it. So one of the things that we did in a national, for example, talking about the National Medical Association, which is the Association of Minority Physicians, in our OBGYN section, we have about 200 to 300 physicians that attend a conference every year. So this past year, we actually had Dr. Pat Catalano to come and give us a lecture and talk about obesity and weight gain during pregnancy. And what we did differently during that conference for the first time is that we had yoga and exercise every morning. Everybody had to come to yoga and exercise. And we actually changed the diet to make sure that the diet was well balanced all day, because we believe that if the physicians become more aware and they also start doing exercise, it'll be easier for them to actually be able to educate other people. So we'll be doing that on a national level. Now, in our practices, and I'm going to run through two different practices just to give an idea about the kind of things that could be done. The first one is a maternal fetal medicine practice. It's located in downtown Los Angeles. They see about 80 plus patients a day. They're all high-risk obstetrical patients that are referred by other people. There are 3 maternal fetal medicine specialists in the office, and there are about maybe 10 medical assistants in the office. And so what we do once the patient comes in, the first thing that she does is that she's weighed. She has to come in and then we classify them into their groups. If they're morbid or obese, we actually take that as an indication for referral, and we actually manage them based on that. And then the next thing that is done is look at their weight gain during pregnancy, and then we do a 24-hour recall of their diet. And then when we do a 24-hour recall of their diet, we have an electronic medical-based nutritional counseling. So the patient says, for example, for snacks, I use crackers and cakes. There's an automatic macro that says if you want to take snacks, use healthy things like peanuts and vegetables and carrots. That actually comes out. If they say that they take two because tortilla is something that our community uses a lot, we'll tell them, okay, if you say you take 3 servings of tortillas, you need to go down to 1. So we actually do an automatic, individualized nutritional counseling at every visit. And then because we know that behavior is very hard to change, those patients have to come back in 1 week so we can assess how well they're doing with that. And when they come back, either an MA or a physician actually sits down with them and goes through the changes that are being done. And then we also really emphasize the exercise. And what we noticed in that practice, which initially I thought was hard to do, was that we had a lot of patients referred because they're diabetic and all that. And we're actually able to take them off medication, many of these patients, because we actually focused on their diet. And one thing became very clear to me in working that practice is that physicians need to be more prevention-oriented as opposed to medication-oriented. And I think because we're medication-oriented, a lot of people are on medications that don't need to. And that patients actually can be motivated if they're actually given the counseling and the advice to do it. And I saw in that population, which is really a low-income population, with very low educational status, actually somebody talking to them every week, meeting with them, sometimes calling them, they were actually able to lose weight, maintain their diet, and get off medications if they're diabetic. So that will be a maternal fetal medicine practice. So now let me go to a primary obstetrical care practice. This practice is also in downtown Los Angeles. It's staffed by residents and midwives. We have about 5 or 6 midwives who are excellent in what they do. They're the framework of the practice. And there again, we see a very highly, we see a population with a very high incidence of obesity as well as type 2 diabetes in pregnancy. Now, the model that we do in this pregnancy is more related to a team care approach. 8 patients are grouped together who have around the same EDC. They start in the first trimester. They meet with a midwife who talks about diet. They bring their meals. They're taught to cook together. They're taught to talk about exercise, and they're followed as a group throughout the whole pregnancy. And one thing that we think that does is that people get motivation from working the group, from from getting ideas from other people and being supportive. And as part of that program, what we did is that after that program, after they deliver, those patients are kept in the program, and they are seen actually nearly every month until either they get pregnant after that or 2 years. And one thing we've noticed that with those group of patients, and this is really just midwives doing this as a basic staff supporters of this patient, is that we were able to get patients to maintain their weight, decrease their weight, so that by the time they got pregnant, and again, following on what Dr. Connie talked about, this is a great time in which we manage contraception, that we really offer contraceptive advice, and patients are to be on contraception. And doing that, we're able to actually make sure that many of those patients in that very, what we call an interconceptional pregnancy care for obese women and women who are gestational diabetes in pregnancy, they were able to change outcome in those patients. So that would be what we've done. And I think on another level is that we also, because I'm also an educator and I work with medical students and residents and fellows as well, one of the things that's also been very important is that looking at it from a perspective of a busy obstetrician is that we have never really focused on nutrition as well as being able to counsel it. And one of the things that I think has been very helpful is actually taking the resident and say, go and look at the weight form. Go to the we have something called CPSP, which is the service that actually provides nutrition for pregnant women. And many of the times the CPSP worker has no direct link with the physicians because the physicians do their own thing. The CPSP workers are somewhere else giving nutrition. So one thing I've always done is have the resident and the medical student and the fellow go and find the CPSP worker, look at the weight gain that the patient has had, and you also in your weight reinforce what the CSP worker has told the patient, because by reinforcing, by message being repeated, it actually gets maybe translated into something that's motivational that patients actually take. So I'll stop there.
So can I, before we move on, can I ask you, with both of those programs, I mean, it sounds like it might have been a little bit of a climate change to get your practice to implement a process like this. I mean, could you shed a little bit of light on how it was to, or how long it may have taken, or how you were able to implement a system-wide, because it involves the whole practice, and I'm sure it involves, if it's linked to a hospital system, kind of buy-in from the hospital to create this kind of environment. Can you give us a little bit of flavor of how easy or difficult it was to create an environment to allow these programs to happen?
I think the reason why they were successful in this case, it was somewhat freestanding. The maternal fetal medicine practice is a private practice by a physician who is being supported by a hospital, but the practice is allowed to create his own mission and his own goals and his own practices. So the reason why that was successful was because the MFM in that group had done a lot of work with genetics and with metabolism, and felt very strongly that a lot of the problems that occurred in pregnancy was related to weight gain, and therefore went out of their way when the program was being created to put an emphasis on weight gain in pregnancy. And so it was basically successful because of leadership. It was the leadership's idea, the leadership's vision that make that work. The other one was also successful because it was a group of midwives who were taking care of who were taking care of patients who had a lot of morbidity and who they felt was related to obesity. So the midwives sat down with the physicians as well as the administrators of the clinic. It was a very large clinic, and because they were the providers and they were interested, so in a way, I'm going to give the credit to the midwives because they pushed it because they felt it was going to be helpful, and that's why that was successful as well. But overall, they were successful because they were relatively small establishments in the sense that they didn't involve a university or a major corporation, and that the leaders there were very interested in making it work. So I believe that the most important thing in the settings that I've been is the leadership and the vision of the leadership.
Thank you. Trustee?
I think as a state agency, our goal, in keeping with the goal of quality services to our clients, we address this in two ways. One is we changed our policies about what should happen within the context of a prenatal visit, and as well as within our WIC program, how prenatal weight gain and weight in general with women could support the IOM recommendations. We also, in order to prepare our providers, developed some materials and tools that they can use with their clients, and integrated the messages or the information at the client level from the IOM guidelines into all our client materials, both for prenatal patients as well as for materials we have to support good preconceptional health. We also provided our providers and local health departments, primarily I would say nurses and dietitians, a lot of training in a lot of different ways to help them have an understanding of why helping their clients meet these guidelines was so important to the long-term outcomes of all our North Carolina population, not just the woman, but the kids. We put a lot of emphasis on weight. We look at the weight gain during pregnancy, but I think we've probably spent more emphasis on looking at our preconceptional care to our clients and how we can help women get to a healthy weight between or after their pregnancy. And we've done that primarily through the WIC program because the WIC program has the luxury, while the woman is not participating, of seeing the kids in that family throughout their first 5 years. And so we've tried to look at a family approach to counseling around weight and moving families to a healthy weight, including the woman. Our state CDC initiative is called Eat Smart, Move More, and we've branched off in many ways from that obesity prevention initiative to do something called Families Eating Smart, Moving More. And we have an array of tools and materials for providers that focus on moving families to a healthy weight. And in North Carolina, that's the approach we've taken. One barrier that we have seen, we offer these same tools and trainings to the private providers. I would say they don't always look to the public health department as the group that guides them in their clinical practice. They look to their national associations from their members. But we did offer it to the private sector. We had some participation, not at the level we had hoped. And their utilization of the tools that we have for providers is significantly lower than it is within our local health departments. We also feel that one of the barriers is that our providers within our health departments need more skills in how to motivate behavior change. And so we have done a lot of work and continue to do a lot of work in helping providers to learn how to counsel and to look at the barriers that are stopping women and families from achieving what their goals are, as well as helping providers learn how to set goals with families. Rather than us tell a woman that they're overweight and this is what they need to gain, or they gain too much weight and now they need to lose this much weight in their postpartum period, help them to work with the family to identify what their goals are and make them achievable goals so that they can be successful. So the next time we see them in the clinic setting, we can say, wow, you did a great job. Is there something else you can work on now? So giving our providers those skills, I would say, is our biggest challenge. Because in a hurried clinic setting, often providers tell us they don't have the time to have that kind of exchange. It's not from a desire to do that. They also feel a bit helpless when a family says the barriers are that I don't have enough money to buy healthy foods and I don't have access to foods. They don't have an answer for them. So helping providers know that they don't have to have all the answers, but at least to acknowledge that those stressors are barriers to making this behavior change. And again, work with clients on small, manageable goals. So I think the clinical information getting out there was the easy part. Making the policy change was the easy part. Getting the tools out there was the easy part. But conveying it and working in partnership with our clients is the hard part. And we're still working on it.
Yeah.
I just want to ask, how much interaction, or can you talk a little bit about the interaction of the WIC programs with the interface with the healthcare system? Because oftentimes you will see these women, even probably before their physicians will see them sometimes, and you'll see them, much longer, kind of in tangential along the way. And so, how much communication kind of goes back and forth? Because it seems like there's a real opportunity to strengthen that communication from what you see and assess in a woman and talk to them and kind of set some groundworks, or even giving them questions to, address with their physician, and then, they go see their physician, or there's some other communication with the physician that they've been to WIC and vice versa. But it seems like that interaction could be stronger, but I was wondering if you could just comment on how that happens in your area.
I think we attempt to have good interactions with private providers and our WIC program, which is housed primarily in local health departments. I would say our success is challenged by the ability to actually have any kind of conversation with providers, and that's a time constraint. It's not for lack of desire on either party's part. We do try to again, by giving, we try to have the WIC program staff encourage their clients to discuss the same issues they discussed with us with their private providers and share the recommendations and their goals for what they're working on. I would like to say that happens every day, all day. I think being realistic, it probably does not happen as often as we'd like. It's the constraints of providing care to so many people in a day on both the private sector's part as well as ours makes that kind of communication challenging. And that's why we attempted to provide the same training and tools to our private sector so that they would be apprised of what we were saying in our local health departments. And what their clients would be told when they came to the WIC program, or they came to the family planning program, or they came to our prenatal program. So when we continue to strive to work through that, we have a really good relationship with the pediatrics group in our state. I think that we don't have in our state as strong an association with the obstetricians and gynecologists. Their association is housed within our North Carolina Medical Society, and so it's hard to get at the subset of that population or that group of providers. It's something I think that we should strive to continue to do, and will. That's something I noted in during this morning presentations is getting with that providers and asking them how we can do this together better.
Great, thank you.
I just want to follow up on the comments about the midwives. One of the hallmarks of midwifery care really is that we are grounded in health promotion and disease prevention as part of one of our skill sets, and something that we focus a lot on within our midwifery education programs. We are very concerned about education, interpersonal communication skills, and really developing those one-on-one relationships as patient advocates. And so I think in terms of providing this kind of guidance as providers, I think we do a really good job. Where we run into trouble is with a lot of the systems barriers that you all were talking about. I think that we need to do more, though, to educate our members about really the honing down to the techniques for the interviewing. I think that that's really key to having the conversation. Even as well versed in the importance of doing this kind of care is as well versed as we are, we really need to sort of give providers more specific guidance as to how to have those conversations. I think developing programs that really say this is an important issue. We know it underlies so many of the other health problems that we're going to see down the road with these folks as they age. Let's really talk about a prevention strategy. Let's really give providers the tools that they need to have these difficult conversations where you really have to, how do you answer when they say, I don't have the money? Well, what do you buy? Do you have WIC? Okay, so what do you get? You have to have a 10, 15, 20-minute conversation. And it's hard to do, but it really is important. And it's something that we just have to make a priority, I really believe. We have to change the paradigm, I think, in some ways with prenatal care, really to focus more heavily on the prevention and the wellness and the health, because we know that most pregnancies, even pregnancies that where the woman has a lot of other issues, they develop well and the woman is healthy in the end. And so while we want to prevent bad outcomes, we also need to remember that this is usually a time of wellness for women, and how can we focus on that? And women are motivated inherently because they want to do the best for their babies. So you've got that element of it, which may be different from to other times in the system where you might find somebody ambivalent about behavior change later on. But when they're pregnant, they really usually are very highly motivated already. It's just how do you get to the behavior change pieces that are very important. I would say that midwives, traditionally, there's a lot of different innovative care models. The group centering pregnancy care model is really wonderful because women weigh themselves, and that's something you can do whether you do group care or not. Instead of having a person put you on a scale and weigh you, what is the value of, and the, in self-advocacy for you as a patient? If you can do it yourself, I'll write it down on the paper. I don't want you to, and there's evidence that women are honest about that when they do that for themselves. So even just starting with some of those simple kinds of techniques. Another thing is, making sure that you do diet recall at every single visit of the prenatal care episode. And if the person can't write, doesn't know what they're doing, or can't, they can't explain it, and there are language barriers, you tell them to take a picture of their dinner with their smartphone and bring it into the next visit. I mean, it's very simple. It takes 2 seconds, and you can see what the portion was from the picture on the screen. And so I think we need to start thinking about what are sort of out of the box, as Dr. Liu said, ways to, instead of just throwing up our hands and saying, well, I gave them the guidelines and I've talked to them, but they don't seem to be responsive. Well, we have to do more. We have to dig deeper. We have to find the roots of the problem, whether it's transportation, access, a misunderstanding about the eating for two myth. Tell them why it's a myth. Well, you only need to gain 11 to 20 pounds because you have 8 pounds of baby, 2 pounds of placenta, a couple pounds of blood, extra blood, and the rest of it, you don't need that extra weight because you're already overweight. And sometimes when you just have that simple, what did it take me, 8 seconds to say that? It says, oh, okay, make it real for the patient instead of this is a number. It's really what is growing in there. Well, you don't need to gain 6 pounds because the baby's this big right now, and and explaining it in a way people can understand. So I think we should also really look towards more discussion of this at home visiting. For example, nurses do a lot of home visiting for vulnerable populations. How much are we really integrating dietary information into those visits? I would say probably a lot less than we could be doing. I think that we just need to really find the creative solutions. And in my personal practice, we do the diet recall. We go over things every time. We send folks to our community, our behavioral health and nutritional counselors. Are we guaranteed that they always go? No. Do we always get a report back? Not always. We're working on it. We're working within the community health system that we have. I think the integrated care models where it's the maternity care home sort of model is also a great way to do things, where you have the one care provider who's doing the coordination and can hopefully do follow-up with all of the referral sites, whether that's across the hall in the next office or across town. So I think that there's just ways of improvement within every health system, and we just have to look for the low-hanging fruit.
Absolutely. So I'm going to go back. You all have touched on this a little bit along the way, but I wanted to bring up something Kathy had mentioned earlier about there's so many resources that are out there. I mean, the guidelines are out there in so many different shapes and forms, and with some organizations adapting the guidelines to meet the needs of their clients, and some of that is, I think, providing the same message. I think we're all trying to do this, have the same goal in mind, but we tailor the messages differently, and that sometimes leads to a lot of inaccuracies. So can you talk a little bit about how you all have taken the updated guidelines and kind of used them very practically in different tools, whether that's social media or pamphlets or educational materials, how you all have done it for your organization, or can just speak to how that can be done and bringing that information on the front line?
I think that if you look at the guidelines themselves, including the previous one, the guidelines have been around for a while. And I think that if we look at our educational model in OBGYN, the guidelines actually are actually taught as part of our education. I think what we've been able to do, what we've done traditionally, is one, to have presentations during our conferences, both at ACOG, at SMFM, and NMA, on this topic, and to broadcast and to, again, talk about the guidelines as well. What we've done on a local level is to actually have ground rounds around the same topic, in various ground rounds sessions. Something we've done before in the NMA was actually at a time to actually get some posters about important topics and actually try to mail them and put them on our website so that they can be used by other people. I think as part of this process, the Society of Maternal Fetal Medicine has created a link on their website so that people who have questions about guidelines can use that. And along that line, the Education Committee of the Society of Maternal Fetal Medicine is interested in looking at what else can be developed that can be shared by the Society of that can be used by the Society of Maternal Fetal Medicine. I think on a practical level in the clinic, which is where everything needs to be done, is that what I've done personally, what we've done is actually to make sure that we get copies of the guidelines, we get copies of that graph, and actually have doctors and the providers look at it. Because one of the problems and the reality is that many of us forget these numbers. Okay, you remember some of it, but you can't remember whether it's 11 to 20 or 11 to 15 at the time you need it, because there are many other things going in your head. But if you have a small form easily available posted to your wall, then it makes you, because sometimes we don't want to say something because we don't remember, and we don't want to say something that's not true, so we don't talk about it. But if it's available, then it makes it easier. So one of the things that I've recommended or will continue to push for is to make sure that you have a copy of that in all offices, posted somewhere where people can look at it easily. But I want to mention, I think one of the elephants in the room about this topic is the importance and fiscal responsibility. The point is that many physicians don't even know, or it's difficult to bill for things related to nutrition. And until you change that paradigm where preventive care can be billed for, then people will see this as something extra. But until it becomes something billable, and what we've noticed is that it's not well known, but you can actually bill for obesity because there's a ICD-10 code for it. But many people are not aware of it. So I think part of this issue will be to actually train and let people know how they can bill for prevention-related services. And once they know they can bill for it, then it's going to be easier. People are going to be more motivated in doing it, because if you keep telling them to do it and they don't think they can bill for it, then it may not really go fast. So I think one of the things we need to do is to actually emphasize the billing aspect and how that can be done as well.
That's a very good point. Very good point. Josephine.
I think I've already touched on that. We have developed an array of materials and tools for providers. One of the things we did was disseminate posters for every waiting room and exam room. Our clients spend a fair amount of time there. I think even within the private sector, you probably have had the experience where you're sitting there undressed for a bit of a time before the provider gets to us, where they can self-assess where their BMI is. And then we have a few key questions at the bottom of that poster that encourages them to talk to their provider about their BMI. And that can be used in any clinic setting. And we just worked on tools that would start the conversation. We've integrated the messages, as I said, into all of our materials and provided training on those materials. We need to do that ongoing because it's not a one-shot deal. Just because you present them a year ago, we have new providers out there. People put things on their shelves. They're busy. And we have to just keep reminding them that they're out there and those tools are available. And this is important. Again, we have moved in our clinic settings, we've moved people away from doing recalls about diet and really moved them towards asking a few key trigger questions. So tell me a little bit about what you usually drink with your meals. Tell me a little bit about how many times you eat out. Is this something you're concerned about? Is this something you'd like to work on? And then we have materials on those topics that are available for providers to guide their counseling as well as have a take home to the client. We find that our clients, the age group that we're serving now, the age of women we're serving, are not as ready to prepare meals at home. So we've done a fair amount to integrate messages about eating at home and how you can do it more easily. We find they perceive cooking at home as a major undertaking, comparable to what some of us might think of at Thanksgiving. And it's just not something they think they can do.
Right.
It's not feasible within the context of their day, and their budget. So they perceive driving through a fast food on their way home from wherever they are as much easier and much cheaper. And our focus groups have told us that. So we're trying to do some education and material development around family meals at home, or at least if you're going to drive through the fast food chain in your area, how you can make some selections that are appropriate. So I think, again, our messages and our materials that we've developed in our training is really focusing on family weight change, and moving to a healthy weight. In the pregnancy period, again, we have a captive audience. They're interested. Working with them on appropriate weight gain is an issue. I think the biggest issue, and for public health, in some cases the more important issue is getting women and families to a healthier weight. So if that woman does have another pregnancy, that the outcome of that pregnancy for the child and for the child is it supports, healthy weight in the future. We've done a lot to focus on breastfeeding because we feel that increasing our breastfeeding rates can also move women towards a healthy weight. And so we're doing a lot in the area of peer support, and the WIC program does a lot with peer support around breastfeeding. Not always emphasizing the issue of weight loss or weight management to the woman is the reason to breastfeed, but it is one component that can move them towards a healthy weight. So we're spending a lot of time on helping all our providers in child health, in prenatal clinics, and family planning to know how to support the breastfeeding woman, because we think that can be another key to supporting that woman moving to a healthy weight.
Thank you.
And in terms of ACNM, some of the things we've done to disseminate the guidelines to our members include sharing them in our weekly e-newsletters. We have had articles in our quarterly newsletter, that one in particular last year, about the new guidelines and about how to talk to patients. And also included, prior to that, we did a little campaign on our Facebook site where we asked midwives, how are they having conversations, how are they counseling women about weight gain, just to get an idea of what people are saying. And that we got some really interesting techniques back about, taking the smartphone pictures, for example. Some people a lot of the respondents really felt that the preconception period was really so key. We heard that over and over again. So I think assessing, your provider populations now and again to find out what creative things are they really doing, and we don't have to reinvent the wheel a lot of times. People have already figured it out. We just need to hear from each other about what we're doing. We also have our professional peer-reviewed Journal of Midwifery and Women's Health, and we've published a number of articles, including from some of the folks in the room here, in our journal, along with the new guidelines. We also disseminate information about events like this on our email list, so that providers know that these conferences are happening, that they're out there. We have a line of patient handouts that providers can use in their offices called Share with Women, that are specially geared to the reading level of an average patient population, and those can be easily handed out. And another thing that we're really trying to focus on more and more is engagement of the actual woman herself. We feel that a lot of work is going on now about the importance of really engaging patients in all aspects of their health care, and we've known this for a long time, but it seems like with healthcare reform and everything that's happening now, we're at a really opportune moment where everybody's kind of coming to the same realization. Why don't we ask the women how they want to be talked to or interviewed, or what they need to know, what would be helpful for them? And so in conjunction with that sort of train of thought, we launched a new consumer campaign whose mission is really a sort of a national awareness about women's health and maternity care and what they might want to know, and asking them. We did a survey in conjunction with this campaign. It's called Our Moment of Truth, encouraging women to become active participants in their own health care. and to learn about the full range of options that they have available to them and what they need to even ask about their health care. Do women even know what they should be learning about when they're pregnant? We surveyed over 1,200 women of childbearing age who had across the board with a racial and ethnic diversity that reflects that of the 2010 census. And women who had given birth recently or were pregnant, and then we found that there's really a major gap between what women say they want in their prenatal care and what they're actually getting. 80% of the women who responded to this survey value a partner in their care, and they really want someone who listens to them, but 50% of women had not had any conversations on any of the typical prenatal care topics that were listed in the survey. So women could go through one by one, topic after topic, and nutrition and wellness care types of questions were in there. And so if half the women aren't having any conversations about things like, not only birth interventions but self-care, that it's not happening across the board. So we really feel that this is where we need to start focusing efforts, because we have the information, we have so many tools for providers, and we do need better tools in terms of engagement, but we also need women to really know what questions to ask. It would be great if they expected us to ask those questions of them. And if we didn't ask them about their weight gain goals or loss goals, or what they'd like to do or how they'd like to us to interact with them, then they should be prompting us. Wouldn't it be great if they were the ones doing the prompting? So we're trying to sort of shift our focus a little bit and get more resources out to women about what they need to be talking about in terms of their pregnancy and their maternity care. And that does include this very important information.
Thank you. Okay, in the remaining time that we have, because I want to make sure everyone gets out on to lunch on time, I'm going to open up the discussion to include the audience with any questions or any experience that you all would like to share, so that we can continue to keep this kind of discussion going. While our first person goes to the microphone, I do want to throw out or bring up a comment with Josephine had mentioned earlier about how can we improve that communication, what can we do? And I think you alluded to it, thinking out of the box and creating this kind of maternal medical home, since the patient-centered medical home is becoming such a tool and a way to bring together in a very realistic way, in real time, a multidisciplinary team that's charged with taking care of a panel of patients, so that it's not this kind of one-on-one doctor interaction anymore, but it really is a group of people with all the expertise that patient needs to say that we are taking care of you and we are going to help you in your care, and really set out care plans and goals. And that might be a very real opportunity to bring the OBGYNs and the family physicians and the pediatricians, and then also reaching out and bringing in those outside organizations, so the community organizations, WIC and La Leche, and all the communities that support the medical profession, but bringing them into that medical home idea too, and kind of thinking very creatively about it. And then using our electronic health record, because it is a great way to link a lot of systems together, and a great way to communicate when you cannot communicate by phone. And I think we do need to become more creative about how to use that tool. Because it's really done a lot to bring primary care and specialists together, and I'm sure incorporating the other professions are going to be important too. So